Welcome to Pediatric Case Review. Today we will discuss pediatric heart failure, a challenging condition that requires early recognition and prompt management. This lecture will provide general pediatricians with practical knowledge on diagnosis, evaluation, and management of heart failure in children. Let's begin with a case. A 3-month-old infant presents with difficulty feeding, sweating, and respiratory distress. Which is the most common cause of heart failure in infants? Is it A, viral myocarditis, B, congenital heart disease, C, cardiomyopathy, or D, Kawasaki disease? The correct answer is B, congenital heart disease. Approximately 75% of heart failure cases in infants are due to structural heart defects. The most common culprits include ventricular septal defects, patent ductus arteriosus, and hypoplastic left heart syndrome. Viral myocarditis and cardiomyopathy are less common but important causes to consider. Which condition is least likely to cause heart failure in a 14-year-old adolescent? Is it A, dilated cardiomyopathy, B, rheumatic heart disease, C, tetralogy of Fallot, or D, anthracycline toxicity? Consider the typical age presentation of these conditions. The correct answer is C, tetralogy of Fallot. This congenital condition typically presents with cyanosis in infancy and would have been diagnosed and treated long before adolescence. In teenagers, acquired conditions like dilated cardiomyopathy, rheumatic heart disease, and chemotherapy-induced cardiotoxicity are more common causes of heart failure. Which compensatory mechanism occurs earliest in pediatric heart failure? Is it A, ventricular hypertrophy, B, tachycardia, C, peripheral vasoconstriction, or D, fluid retention? Think about the body's immediate response to decreased cardiac output. The correct answer is B, tachycardia. Unlike adults, children depend heavily on heart rate to maintain cardiac output. When cardiac output falls, increased sympathetic activity immediately raises heart rate to compensate. This is followed by peripheral vasoconstriction, then fluid retention, and eventually ventricular hypertrophy as a long-term adaptation if the condition persists. A 6-month-old presents with poor weight gain and increased work of breathing. Which feeding symptom is most specific for heart failure in infants? Is it A, prolonged feeding time, B, decreased appetite, C, frequent spitting up, or D, crying during feeds? The correct answer is A, prolonged feeding time. Infants with heart failure typically take longer to feed due to fatigue and respiratory distress. They often need to pause frequently to catch their breath. This, along with diaphoresis during feeding, is highly suggestive of heart failure in infants. Prolonged feeding time may be the earliest symptom before more obvious signs of heart failure develop. A 10-year-old with heart failure presents differently from an infant. Which symptom is most common in older children? Is it A, exercise intolerance, B, feeding difficulties, C, irritability, or D, failure to thrive? Consider how symptoms might manifest differently based on developmental stage. The correct answer is A, exercise intolerance. Unlike infants who show feeding difficulties, older children with heart failure typically present with decreased exercise tolerance, fatigue, and dyspnea on exertion. They might also complain of abdominal pain due to hepatic congestion or generalized fatigue. These symptoms reflect the same pathophysiology but manifest differently due to age-related activities and ability to communicate symptoms. A 4-month-old presents with suspected heart failure. Which physical finding has the highest sensitivity for heart failure in infants? Is it A, hepatomegaly, B, peripheral edema, C, RALS, or D, S3 gallop? Consider the typical physical exam findings in pediatric heart failure. The correct answer is A, hepatomegaly. An enlarged liver is present in over 90% of infants with heart failure and is often the most reliable physical finding. Unlike adults, peripheral edema is relatively uncommon in infants with heart failure. RALS may be present but can be difficult to distinguish from normal breath sounds. An S3 gallop is specific but can be challenging to detect in tachycardic infants. A 2-year-old presents with tachycardia, tachypnea, and poor perfusion. Which vital sign abnormality would most help differentiate cardiac from respiratory disease? Is it A, respiratory rate greater than 60, B, heart rate greater than 180, C, hepatomegaly with normal lung exam, or D, blood pressure below the 5th percentile? The correct answer is C, hepatomegaly with normal lung exam. The combination of liver enlargement without significant lung findings strongly suggests a cardiac etiology. Both respiratory and cardiac conditions can cause tachypnea and tachycardia. Hypotension is typically a late and ominous finding in pediatric heart failure. Remember that respiratory distress in children often has respiratory causes, but these key differentiating features can help identify cardiac disease. An 8-month-old presents with suspected heart failure. Which test should be ordered first in the evaluation? Is it A, brain natriuretic peptide, B, chest X-ray, C, echocardiogram, or D, electrocardiogram? Consider the availability, cost, and diagnostic yield of these tests in the initial workup. The correct answer is B, chest X-ray. A chest radiograph is typically the first imaging study obtained due to its wide availability, low cost, and ability to provide important information. It can quickly demonstrate cardiomegaly, pulmonary vascular congestion, and pulmonary edema. While echocardiography is the gold standard for diagnosis, and BNP is useful for screening, a chest X-ray is usually the appropriate first step in evaluation. Which statement about B-type natriuretic peptide, or BNP, in pediatric heart failure is correct? Is it A, levels above 100 picograms per milliliter confirm heart failure? B, BNP is typically lower in children than adults? C, serial measurements aren't useful for monitoring? Or D, levels don't correlate with severity? The correct answer is B, BNP is typically lower in children than adults. Normal BNP values in children are age-dependent and generally lower than adult values. This makes it essential to use age-appropriate reference ranges. BNP does correlate with heart failure severity in children, and serial measurements are valuable for monitoring disease progression and treatment response. While elevated BNP supports heart failure diagnosis, no single cutoff value is diagnostic across all age groups. A 6-year-old presents with heart failure symptoms. Which echocardiographic parameter is most useful for assessing systolic function in children? Is it A, left atrial size, B, E/A ratio, C, ejection fraction, or D, tricuspid regurgitation velocity? The correct answer is C, ejection fraction. Ejection fraction remains the most commonly used parameter to assess systolic function in children, with normal values ranging from 55 to 70%. Left atrial enlargement is a marker of chronicity but doesn't directly measure function. The E/A ratio assesses diastolic function. Tricuspid regurgitation velocity is used to estimate pulmonary artery pressure. Additional systolic parameters include fractional shortening and global longitudinal strain. A 9-month-old presents in acute heart failure with respiratory distress. Which medication should be administered first? Is it A, furosemide, B, digoxin, C, captopril, or D, milrinone? Consider the priorities in managing acute heart failure. The correct answer is A, furosemide. In acute heart failure with respiratory distress, the priority is to reduce pulmonary congestion. Intravenous furosemide at 1 mg per kilogram provides rapid diuresis and symptom improvement. Digoxin has a narrow therapeutic window and is now used less frequently. ACE inhibitors like captopril are important but introduced later when the patient is stabilized. Milrinone is reserved for decompensated heart failure requiring inotropic support. Which medication class has shown the most benefit in chronic pediatric heart failure with reduced ejection fraction? Is it A, beta blockers, B, ACE inhibitors, C, aldosterone antagonists, or D, digoxin? Consider the evidence base for different medication classes in pediatric heart failure management. The correct answer is B, ACE inhibitors. While pediatric heart failure trials are limited compared to adult studies, ACE inhibitors have the strongest evidence base for improving outcomes in children with reduced ejection fraction. Medications like enalapril, captopril, and lisinopril reduce afterload and cardiac remodeling. Beta blockers and aldosterone antagonists are used but have less pediatric-specific evidence. Digoxin's role has diminished, though it may still have benefits in certain scenarios. A 12-year-old presents with decompensated heart failure despite maximum medical therapy. Which mechanical support option is most appropriate as a bridge to transplant? Is it A, ECMO, B, ventricular assist device, C, intra-aortic balloon pump, or D, dialysis? The correct answer is B, ventricular assist device. For longer-term support as a bridge to transplant, VADs are generally preferred over ECMO, which is typically limited to short-term support of days to weeks. The Berlin Heart X-Core is approved for smaller children, while older adolescents may receive adult devices like the HeartMate 3. Intra-aortic balloon pumps have limited use in pediatrics. Dialysis may help manage fluid overload, but doesn't provide cardiac support. Which factor is associated with the worst prognosis in pediatric heart failure? Is it A, congenital heart disease etiology, B, age less than 1 year at diagnosis, C, preserved ejection fraction, or D, protein-losing enteropathy? Consider the factors that influence long-term outcomes. The correct answer is D, protein-losing enteropathy. This complication indicates severe right heart failure and carries a poor prognosis with 5-year survival rates below 50%. While young age at diagnosis and certain congenital heart diseases can have poor outcomes, they are highly variable based on specific conditions and interventions. Heart failure with preserved ejection fraction typically has a better prognosis than reduced ejection fraction in children, unlike in adults where they may be similar. A 7-year-old with chronic heart failure presents with poor growth. Which nutritional complication is most common in chronic pediatric heart failure? Is it A, iron deficiency anemia, B, vitamin D deficiency, C, protein malnutrition, or D, zinc deficiency? The correct answer is A, iron deficiency anemia. Iron deficiency affects 60 to 80% of children with chronic heart failure due to poor intake, intestinal edema causing malabsorption, and chronic inflammation. Treating iron deficiency, even without anemia, improves exercise capacity and quality of life. While other nutritional deficiencies can occur, including protein malnutrition and vitamin D deficiency, iron deficiency is the most prevalent and has the strongest evidence for targeted intervention. Thank you for joining us for this comprehensive review of pediatric heart failure. Remember that early recognition, proper diagnosis, and age-appropriate management are crucial for improving outcomes. Heart failure in children presents and is managed differently from adults, requiring pediatric-specific approaches. We hope you found this presentation valuable. Please follow the Pediatric Case Review channel for more informative presentations and leave any questions in the comments section below. Your engagement helps us create better educational content for the pediatric community.